So in today's topic, severe acute malnutrition, page number and chapter number, please mention in the chat box based on the new textbook. If anyone is joining late, please help them out with the page numbers or the topic name. It's severe acute malnutrition from your nutrition science textbook. (160) page number. If anyone is joining late, please help them out with the page numbers. So severe acute malnutrition, what is it? It is defined by a very low weight for height or by length. Okay. By visible severe wasting. What is wasting? Loss of muscular mass. Okay. Or by the presence of nutritional edema or pitting edema. Either the child will have severe muscular wasting, body wasting, or the child will have nutritional edema. All over the body, there is a swelling present. Either of the two cases. And there are some situations, a type of severe acute malnutrition in which both of these signs and symptoms you will see. We will discuss that in detail in the coming slides. Okay. So even according to WHO, World Health Organization, children who are below 5 years of age, okay, children who are below 5 years of age, in them, severe acute malnutrition is defined by very low weight for height. For every height or every growth in length, okay, if the child has not started walking, we measure the length of the child. Once the child is able to stand erect on their own and start walking, okay, we measure the height of the child, okay. Or clinical signs, or there are bilateral pitting edema or muscular wasting, okay, and even the upper arm circumference, mid upper arm circumference is very low, okay. In all these cases, we call it as a severe acute malnutrition. And every year it is seen that annually around 19 million children under the age of 5, they die, okay. And it accounts for approximately 4 lakh child deaths on a yearly basis, okay. So even on top of that, if you see children who pass away, mortality rate in children, the child who is under the age of 5 will always have the highest mortality rate. Once the children has crossed the age of 5-year-old, okay, once the children has crossed that age group of 5-year-old, the mortality rate dips, okay. Otherwise, every child who is under the age of 5, the death rate is high, okay. Am I audible to all? Is the class visible? Okay. So that is severe acute malnutrition. It is also a situation that the UNICEF and other World Health Organizations are finding it challenging to combat, okay, especially in underdeveloping countries, okay. And not every child who is suffering from severe acute malnutrition requires hospitalization. Nutritional intervention done at home at domiciliary level can also cure it, okay. So mid upper arm circumference, which is very easy, okay, you don't require any invasive device in this, okay. That is the reason why you have to teach this to mothers, okay, who have just given birth. Teach them the importance of mid upper arm circumference, okay. Once the child has crossed 6 months of age, okay, once the weaning diet you have started, now the child is not on complete breastfeeding, okay, exclusive breastfeeding, the child is also taking weaning diet, okay. So in that case, when you come across these mothers, you have to guide them about the importance of always checking once a month, always checking your child's mid upper arm circumference. How do you do that? You first have to take the length of the shoulder and the elbow. From the tip of the shoulder to the tip of your elbow, of the child's elbow, what is the length? And divide that length by 2. Okay, you will get the middlemost length. Okay, you will find the middle part. And there you have to place the measuring tape and check the circumference. Okay, if the child's mid upper arm circumference is less than 11.5 centimeter, in centimeters, if you see, if it is less than 11.5 centimeter, it means the child is undergoing malnutrition. Okay, there is wasting, and there is a standard deviation score. Standard deviation score means plus or minus. Okay, less than, especially if it is going into minus. Okay, 11, 10.5, 9.5. Okay, these are situations of severe wasting. Okay, so you have to calculate the standard deviation is also 3 standard deviation, up till 3 standard deviation. Okay, so this calculation is done in children who are between the age of 6 months to 5 year of age. 6 months to 5 year of age. Okay, you can't do the mid upper arm circumference for a 6-year-old child. Okay, or you can't do a mid upper arm circumference for a 4-month or 5-month-year-old 5-month-old child. Okay, but the child has to cross 6 months of age and up till 5 years of age. Mid upper arm circumference is a valid measurement to identify malnutrition. Is it clear to all? This is kind of a health education, and it is very easy. Okay, you don't require any injections or anything. Even if the mother knows the importance of mid upper arm circumference, she can catch malnutrition at an earliest point and start treatment. You don't have to wait for the child to get other conditions like kwashiorkor or marasmus. Okay, so these are the classifications of severe acute malnutrition. You have kwashiorkor and marasmus. Okay, so in clinical classification, clinically, if you see the symptoms, okay, symptom-wise classification, if you do, you can either find severe wasting. You can see here in the case of marasmus. Okay, the child is so skeletal. You can actually count the rib cage. Okay, the ribs on the child. The bony prominences in this child's body is very visible. Okay, even the cheek fat. Children usually have that bad baby fat. Okay, they have this chubby cheeks and all baby fat that is completely lost, and because of which the child will have an old man kind of a face. Okay, so you can see this is a severe wasting clinical classification. Okay, no muscles at all, muscles, subcutaneous fat, everything is lost. This is the case of marasmus. Okay, then you have nutritional edema. Come to the image A, kwashiorkor. Okay, here you can see the child has this protruded belly. This is edema. This is fluid filled belly. Okay, the peritoneal cavity becomes filled with fluid. And also not just the abdomen. If you notice the child's calf region, ankle region on the legs, lower part of the legs, okay, that is also edematous. Okay, swollen ankles, distended abdomen, ascites. Ascites means peritoneal cavity becomes filled with fluid. Okay, skin is very scaly. Skin is very reflective. Okay, if you have seen the scales of the fish, it can reflect back the light. Okay, so the child's skin also looks very reflective. Okay, coming to the classification based on complication, you have uncomplicated severe acute malnutrition and complicated severe acute malnutrition. Uncomplicated, no need for hospitalization. At home, nutritional interventions can be done with the help of PHC sub-centers. Okay, some Anganwadi services based on this. Some nutritional interventions can be done at a domiciliary level, at home level. You don't, and sometimes you will just once a week you will have to take your child to the clinic, to the pediatrician, to monitor the growth, to monitor the changes in the child. That's it. Okay, there is no requirement for hospitalization. You don't have to admit the child in cases of uncomplicated SAM. Okay, complicated severe acute malnutrition, it could be life threatening if you don't admit the child to a hospital. Okay, because certain signs and symptoms like hypoglycemia, hypothermia, okay, very low levels of vitamin A, which could lead to blindness. Okay, these kind of complications will be there. Child may go into fits, seizures. Okay, child may go slip into a comatose situation, slip into coma. Okay, so these complications will be arriving. A lot of infections also. Malnourished children are already at a higher risk of developing a lot of infections. So the child may also exhibit symptoms of infections. Okay, so that comes under complicated severe acute malnutrition. So this is the classification. Is it clear to all? Coming to the clinical features. Now this is very important. You can expect a lot of questions from this. Okay, clinical features of kwashiorkor and marasmus. Okay, so first we will see marasmus. There is a table, an entire explanation, a full page lengthy explanation of clinical features are given in the textbook. You can read that later, but these are the same points you will find there. Okay. So marasmus you usually see in infants. Okay. Marasmus is usually seen in infants who are less than 1 year of age. Okay. If malnutrition hits a child who is about 1 year of age, less than 1 year of age, usually it will be marasmus. If the child is more than 3 years of age, okay, usually it could be kwashiorkor. Okay, marasmus is very evidently it happens in children who are less than 1 year of age. And why does this happen? Due to low calorie intake, or sometimes weaning diet is not up to the mark. Weaning diet is not giving adequate amount of fat or calories. Okay. So due to low calorie intake, the child may have marasmus. Severe growth retardation. Okay, the child will not put on height, and also the child will not be able to walk on time, crawl on time. Severe reduction in body weight. It's very visible, it's very evident. If you lose a lot of fat from the body and muscles from the body, your weight will be down. Okay. Shrunken abdomen and subcutaneous fat, it is not at all preserved. That's why you get a old man kind of a look. Wrinkled face. Okay, the face looks like that of a that of a senior citizen. Okay, there's a lot of wrinkles because the child has lost all the subcutaneous fat. Fat just beneath the skin is called the subcutaneous fat. Okay, shrunken abdomen, and because of the shrunken abdomen, the rib cages, okay, ribs are very much protruded. You can actually count each of the bones. Very prominent ribs. The child is a voracious feeder. Child is very hungry. Okay, the appetite is a lot in the child. Child eats a lot. Okay, but still the child will not put on weight because when the body reaches this stage of marasmus, intestine intestine, which should absorb the nutrients, intestine undergoes atrophy. Atrophy means it shrinks. Intestines of the child will shrink. It will become smaller. It will not function properly. So because of these complications, whatever feed you give to the child, it is not well absorbed by the body. Okay, so the child eats a lot. Child is hungry. Okay, child has a lot of appetite, but it cannot keep up with the body's requirement. Okay, no fatty liver is seen here. Edema is not present. An old man kind of a face. No hair changes is noted. Dry and wrinkled skin because of dehydration and loss of fat. The child is alert. Okay, not unconscious. The child is alert, but the child is very irritable. Okay, they get very easily angry. They throw a lot of tantrums. Even if you admit the child is so irritable that it will keep on crying, making sounds, noises. Okay, not allow. They will usually, we have seen in pediatric cases that marasmus children, they don't even allow doctors or nurses near them. okay, for when the medications has to be given, or if the child has to be put on IV fluid and all, okay, they are very irritable. They start hitting the doctors and nurses as well. Those cases also have been seen. Okay, so child is very irritable. Okay, and requires adequate amount of protein, fat, and carbohydrate. All macronutrients here is required. You have to make an intervention which can provide all these three macronutrients so that the child can be brought back to health. Okay, so this is about marasmus, clinical features of marasmus. Next, you have kwashiorkor. So kwashiorkor word, it is from an African language, which means an elder child, disease of an elder child. Okay, why elder child? Because usually this disease is, majority of the cases, this disease is seen in children between the age of 3 to 5. Okay, that gap between 1 to 3 years, it is marasmic kwashiorkor. Okay, but above the age of 3, if the child is malnourished, usually it is kwashiorkor. Below the age of 1, if the child is malnourished, it is marasmus. Between this 1 and 3-year-old age gap, okay, in this case, in this age gap, if the child is malnourished, it is marasmic kwashiorkor. We will see that later. Okay, so usually it is seen in preschool children uh, due to low protein intake. Okay, the child has adequate fat in the body, the child has adequate carbohydrates as well in the body. It is because of the protein deficiency in the diet, the child may go into kwashiorkor. Okay, there is mild growth retardation, not severe. Severe growth retardation is seen in marasmus. In kwashiorkor, it is a mild growth retardation. Mild reduction in body weight, not much, because the body is in a state of edema. So you will not see a drastic reduction in weight, okay, because the water weight, the water content, retained water also adds weight to the body. The child will have a protruded abdomen. This is ascites, you can see here, it is called ascites. And the subcutaneous fat of the child is not lost. Okay, the child will not lose fat under the skin. Okay, so ribs are not at all prominent here because of edema, but the child has poor appetite. Here in marasmus, the child is a voracious feeder, eats a lot. But in kwashiorkor, the child has no appetite and the child has enlarged fatty liver. Okay, too much of fat, that fat that was not digested well, not utilized well, gets accumulated in the liver, and there is a risk of fatty liver. Edema is present all over the body. There is moon face because of fat present under under the skin, as well as water retention. Okay, the child will have sparse hair changes will be there, and also the color of the hair, it it becomes lighter. Okay, and the skin will be like a flaky paint like skin, scaly skin. Okay, like fish scales. It dries off and comes off, and it has a sheen. It has a reflection. Okay, that's the skin of a kwashiorkor child. And the child is lethargic, no energy, and requires adequate amount of protein to correct the situation. Okay. So that's about kwashiorkor and marasmus, the clinical features. This is the third case called marasmic kwashiorkor. Okay. Usually it happens in a child who is between the age of 1 and 3 years of age. Okay. You will see the symptoms both of marasmus and kwashiorkor exhibiting here. If the image is clear to you, okay, this is a severely malnourished child with features of both marasmus and kwashiorkor. Okay. If you look at the child, you will see if you take the thoracic cavity and the abdomen cavity, okay, from neck to the pelvis, if you divide this in half, the upper part of the body, the chest, upper arm, it is severely wasted. You can see the ribs here. Okay, if the image is clear, you can see the ribs here. Okay, but the lower part of the body, from elbow to the fingertips and the stomach area, it is bulging out. Okay, it is edematous. So that is the sign and symptom of kwashiorkor. Okay, even in the legs, you see the upper part of the legs are very skinny, but the lower below the knee, the ankles, feet, okay, it is edematous. Okay, so this is a case of marasmic kwashiorkor. The child has both the signs and symptoms of marasmus and kwashiorkor. Even if you just see the hair, okay, the child does not have sparse hair. There is the quantity of the hair, there is no change, but the color you can see, the color is just like a kwashiorkor hair. Okay, the color of the hair is very light. Based on the ethnicity of the child belongs to an Indian ethnicity. Based on the Indian ethnicity of the child, the hair color is not there, it is light, but the hair is not sparse here. Okay, this is not a sparse case, this is a light hair case. Okay, so kwashiorkor, the features of kwashiorkor are seen in feet, legs, also hands, lower arms, abdomen, even in face you find moon face. Along with that you also find indents. Okay, that is of marasmus. The child is very unhappy, not excited or not energetic. Other forms of uh, malnutrition, the child in the center is of a certain age, and this is a normal height and weight gain of a child. Okay, the child on the left side is stunted means this child is has not attained the same length or height, okay, as per their age, but there is not much change in the weight gain. Okay, weight gain is almost uh, average to whatever height the child has, but the height is not adequate enough based on the child's age. That is stunted. Okay, you don't grow vertically. Okay. The other case on the right is a case of wasted. Okay. Here, the child is almost, not exactly, almost able to keep up with the height, but the child has completely wasted the body fat and muscles. Okay, so this is the case of a wasted child. So that is the difference between stunted child and a wasted child. Okay, in respect to a child who has a normal height and weight. So this is also the figurative explanation of the same. Different types of childhood malnutrition. There is a height for every age, a normal height range for every age. So this is the normal child on the extreme left. The child, then next to it is a wasted child. The child who is undergoing wasting is able to keep up with the height. Okay, but they are extremely skinny, extremely thin, because there is not enough fat or muscle built on their body. Next, you have stunted child. Okay, not at all keeping up with the height, but their weight is almost normal based on whatever height they have acquired, even though the height is abnormal based on their age. But according to that height, they have enough fat in their body, they have enough weight for that body. Okay. And then you have underweight child. Underweight child neither have reached adequate height, neither they have reached adequate weight. Okay, low weight for age. Is it clear to all the different types of childhood malnutrition? Next is changes in the organs and systems. Digestive organs, as I have mentioned earlier, the gut, the intestine, they all undergo changes during malnutrition. Pancreas will not secrete enough pancreatic enzymes, pancreatic juices, insulin, glucagon. These things will not be secreted in enough quantity. Stomach will not secrete enough amount of hydrochloric acid or mucus. Okay, intestine will become smaller. The intestinal villi, okay, that is the finger-like projections in the lumen of your intestine. are supposed to absorb or hold on to nutrients. They become shorter. If they are short, they will not be able to absorb nutrients. So these are changes that come, and also either the child will suffer from severe diarrhea or constipation. Okay, diarrhea is very common because along with certain infections, the child will suffer from diarrhea. Then liver. When it comes to kwashiorkor, there would be a fatty liver. In case of marasmus, liver is relatively healthy, but it is depleted out of all nutrients. Okay, liver will be depleted out of all nutrients. But in case of kwashiorkor, you will see fatty liver. Fat deposits on the liver because fat metabolism is not taking place properly in kwashiorkor. So additional fat will just go and deposit itself on the liver, leading to fatty liver. Then you have cardiovascular system. Heart becomes smaller in size. Okay, heart rate slows down. Cardiac output, initially it will be high, later it will slow down. Okay, the child will go into a state of hypoxia because heart is not able to pump enough blood into the organs, into the tissues. Okay, the child will go into a state of hypoxia. So cardiovascular system also fails slowly. Okay, the heart has reduced in its size. The cardiac output has reduced. Heart does not have the uh, vitality to pump more blood. Okay. Next, you have kidneys. If anything goes wrong in the cardiovascular system, kidneys will also have the brunt of it, especially when it comes to kwashiorkor. Okay, kidneys are not able to take out the additional fluid and keep it out of the body. That's the reason why the body goes into a state of edema. Okay, if kidneys were working properly, kidneys were able to filter out the blood properly. Okay, the child will not go into a state of edema. And here, the glomerular filtration rate in the kidneys will also go down. That is a filtration rate. Okay, per minute, how much blood gets filtered. These are the glomerular filtration rate. It slows down, it decreases. Okay, so more and more water retention happens. Kidneys are not able to give urinary output. Okay, the child is not able to urinate or produce urine. Then immunological system in both the cases, marasmus as well as in kwashiorkor, immunity goes for the toss. Okay, the child is at risk of developing severe infections. Then mental development. Mental retardation is seen in marasmus cases more than kwashiorkor. But any of the malnutrition can lead to mental retardation. Okay, the child will not have a proper cognitive development, motor skill development. Okay, these things will be delayed. Then hormones. Table 8.2, page number you can mention in the chat box about the hormones, how the endocrine system gets affected when it comes to malnutrition. All the hormones will reduce. Okay, the secretion of all hormones will go down because to make hormones you require cholesterol. In marasmus there is no fat in the body. Okay, there is not enough cholesterol in the body. How will the body prepare hormones? Okay, cholesterol is a major component for the production of hormones. Without it, the body will not produce enough amount of hormones, and all the hormonal imbalances will creep in. Okay. Coming to the biochemical and metabolic changes. So protein in marasmus as well as in kwashiorkor, protein, the way how protein is digested, it gets affected because the pancreas are not able to produce protease enzyme for the breakdown of protein. If the protein is not being broken down, how will the amino acids be formed, and how will the body get all the necessary amino acids? Okay, so protein metabolism will be affected. Lots of protein as it is in the form of nitrogen losses will be there, urea losses will be there, and high amount of protein loss will be there from the body. And also the body in this situation goes into a state of catabolism, in which to meet its protein requirements, body will break down its own muscles, its own protein stores to meet its protein requirements for survival. Lipid metabolism gets affected. The bile salts produced in the malnourished child's body is not enough. Okay, so emulsification won't take place properly, and even the amount of lipids are uh, that are produced, okay, that are absorbed, they are not able to be, they are not well transported through the bloodstream because of the absence of protein. The child will not have enough amount of lipoproteins to transfer the lipids from one point to the other. So what happens? All the major fats will just go directly to the liver and stay there. And the body is not able to take the fat away from the liver because of the absence of lipoproteins. Okay. Carbohydrates. In kwashiorkor, carbohydrates is not a big issue, but in marasmus it is. Carbohydrate deficiency is also a cause in marasmus. The child goes into a stage of hypoglycemia, okay, which could be deadly. Okay, if hypoglycemia is not treated on time, it could lead to death. Okay, so carbohydrate metabolism gets affected. Body is not able to store glucose in the form of glycogen, and even the glycogen stored in the body cannot be converted to glucose because of the absence of glucagon hormone. Okay, so because of these reasons, carbohydrate metabolism also affects. So electrolyte and water balance imbalance, systemic diarrhea, okay, frequent diarrhea, systemic diarrhea are the reasons why the child will suffer from electrolyte and water imbalance. ORS is prescribed here. The child will be put on ORS along with the nutrition therapy. Carbohydrates cannot be broken down properly, and even if the glucose carbohydrates that has been broken down and absorbed by the intestine, and it is stored in the liver and muscle, it has to be converted into glucose back. It has to be converted back into glucose, put into the bloodstream, then be used by the body. This conversion will not take place. Okay. So vitamin A, as soon as a child with severe acute malnutrition, when they come to a clinic, okay, kwashiorkor, marasmus or marasmic kwashiorkor, when they come to a healthcare facility, immediately vitamin A doses will be given. Okay, why vitamin A doses? Otherwise, the child is at the risk of developing irreversible blindness. Okay, the child will go blind because of nutritional deficiency, and that is irreversible. Okay, because of vitamin A deficiency, if the child is turning blind, it is irreversible. So immediately on day one itself, vitamin A prophylaxis will be given. We will see the vitamin A prophylaxis later, how it is given. So coming to the treatment part. See, the treatment part, until and unless you are not a pediatrician, you are not supposed to be giving any of the treatment of severe acute malnutrition. But as a nutritionist or dietitian, you should be aware of what is the principle of the treatment. Okay, having the awareness of this, you can guide someone who requires help, guide some parents who require help. Okay, guide them towards a pediatrician, towards a child healthcare center. Okay, from there, the children will get the complete treatment. But to give them proper guidance, to take away their uh, whatever myths they may have, okay, you should have a basic knowledge. Okay. Vitamin A deficiency, there is no specific reason for vitamin A deficiency. If the child is malnourished, the child is deficient in all the aspects of vitamins, minerals, macros, and micros. Okay. But vitamin A deficiency is more risky because all the vitamin C deficiency, it can be corrected. Vitamin D deficiency can be corrected. Vitamin E can be corrected. Antioxidants can be corrected. But any harm caused to the child because of vitamin A deficiency cannot be corrected. Okay. So that is the reason why vitamin A is given more importance, because it leads to blindness. Okay. That is a nutritional blindness. And that is for lifelong. The child becomes uh, handicapped for their entire life. Okay. So we are because of vitamin D, vitamin E, or vitamin C, the children don't become handicaps. Okay. But because of vitamin A deficiency, you're taking away a sensory organ, function of sensory organ of the child. Okay. So that has to be avoided. So first, nutritional requirement has to be corrected. There are lots of formula diets, F75, F100, RAFT, okay? At a hospital level also, nutritional requirement will be corrected. The first few days, the first 3-4 days, the child will spend in ICU, and then the child will be put into a regular pediatric ward, and treatment will be continued. Why the child will be in ICU? Because if the child is suffering from hypothermia, hypoxia, hypoglycemia, these conditions are life threatening. Severe infections, sepsis, okay, these conditions are life threatening. So, to deal with life threatening conditions, the child has to be in ICU for the first few days. Then the child will, when the child's health progresses, okay, the child will be put back into other regular pediatric ward. Okay. So in nutritional requirements, energy, in your textbook, you can see how much energy is required. You can't dump the child with high energy food in the first place. Okay, you have to slowly introduce high energy food. Okay, 50 kilocalories on a daily basis increase can be given. Okay, 75 kilocalories per kg body weight can be given initially. Then slowly it can be turned into 80, 85, 90, 100, like that. Taper the calories slowly into the child. Okay. So that is how energy requirement has to be kept up. Just read the paragraph in the textbook. You will understand how it is. Then protein around 2 grams of protein per kg body weight at least has to be given. This is high amount. Okay. But why? Because the child has to overcome the growth retardation. Okay. Oh, the child has to keep up with the growth of its peer. Okay. So high protein has to be given. Only then the child will grow in height, gain weight, gain muscle. Okay. And they can compete with their peers of the same age, healthy peers. Okay. So at least 2 gram per kg body weight protein has to be given. It cannot go less than that. Okay. It should not go less than 2 grams. Again, in the textbook, if it is given 5 grams, it is the pediatrician who decides. Okay. To be on the safer side, you can't dose the child immediately with 5 grams the day one itself, because the child will be in ICU. Okay. So once a child is out of ICU, 4 grams per kg, 5 grams per kg can be given. But even in the ICU, at least 2 gram per kg should be maintained, not less than that. Okay. This exact gram value will be decided by the pediatrician. Okay. Fats also, in case of marasmus, high fat diet is given, but in kwashiorkor, high fat is not given. Okay, the child is already suffering from fatty liver, so healthy fats, LDL fats has to be avoided. HDL fats can be given. Okay, healthy fats has to be given in control for kwashiorkor. In marasmus, you can be liberal with the fats and carbohydrates. Electrolytes, the child will be put on ORS. Okay, 24 hours ORS feed has to be maintained in the initial few days. That is, even if the child is sleeping at night, the child will be woken up and the ORS will be given to the child. Okay, and then the child is put back to sleep. And if the child is not taking anything from mouth, okay, then IV fluids will be ongoing. Okay, through intravenous fluids also, you can correct the electrolyte rate. Then vitamins, multivitamin doses can be given either through intravenous fluids. Okay, vitamin A prophylaxis, it is given through, or it is given orally. Okay. So vitamin D injections can also be given orally. It can also be given. Certain vitamins injections will also do. Okay. That depends on the pediatrician. Based on the child's prognosis, the pediatrician will decide which route of administration is decided for vitamins. Coming to the management part, you have, as I mentioned, initial treatment is done in the ICU. Okay, where hypoglycemia, hypothermia, hypoxia, sepsis, infections, these has to be corrected. Okay, when the child is out of hypothermia, hypoglycemia, within few hours only, as soon as you put the child on glucose, okay, DNS is put on the child. Okay, within few hours, the child's hypoglycemia will be corrected. Okay, the child's blood glucose level will come back to normal. Okay, in the ICU, within a day, the child's hypothermia can be corrected. The child can be put under radiant warmers. Okay, warm blankets can be put or given to the child. AC can be turned off. Okay, for the child's bed. So like that, these strategies can be used to bring down the to bring up the temperature of the child. Okay, so hypothermia can be corrected. And if there is infections, based on the blood sample, based on the swabs from the child's body, identify what exact infections, what exact bacteria are causing the infection, or any viruses are causing the infections. And accordingly, antibiotics, antivirals, whatever is the causative agent of infection, antibiotics, antivirals, antifungals should be prescribed. Okay. So these initial treatment will be carried out in the ICU. Rehabilitation will be done in the general pediatric ward when the child is out of danger. Okay, when the child is out of life-threatening conditions, the child will be shifted to a regular ward, and from there, if any infections are still persistent, antibiotics or antivirals will continue. Along with that, now we can focus more on the nutrition, how to rehabilitate the child nutritionally. Okay, how to bring back the growth in the child, how to bring back the weight in the child. Okay, weight gaining is of importance here. Improving child's appetite is important. Keeping the child alert is important. Teaching the child to ask for more food whenever the child is feeling hungry. Teaching the child this. Teaching the parents on what feeds to be given, in what intervals, what kind of food has to be given, what strategies can the parents use so that even in small quantity, high density, high nutritionally dense food can be given. Okay, these things are taught to the parents. Then in follow-up, the child is discharged. Okay, the child goes back home, and even at home, see, home environment is one of the major causes that leads to malnourishment. Usually, the social factors like poverty, living below poverty line, non-accessibility of food, okay, gender bias in children, okay, these things are the social factors that lead to malnutrition. So when the child is going back home, the child is definitely going back to the same environment. You can change the health of the child in a hospital, but you cannot take the child out of poverty. The child is still going back into poverty. Okay, so how can you impart some knowledge in parents? Because even if the child is going back to the poverty, going back home, the child is still poor. The parents may be still daily wagers. Okay, they cannot afford milk, egg, Okay, these kind of high nutritious food for the children. So what other alternatives can they have? What government schemes are they not aware of? You can make them aware of. Okay, so these things you have to, when you're discharging the child and when you're calling the child back for follow-up services, these things has to be taught to the parents. So here, this is the table format of initial treatment, rehabilitation, and follow-up given. So here you can see the first 2 days, or sometimes if the condition is very severe, the child may have to spend an entire week in ICU. Okay. So in the initial treatment, you are treating hypoglycemia, hypothermia, dehydration. That is also that could also lead to mortality if dehydration is not corrected. Okay. So hypoglycemia has to be corrected in ICU, hypothermia, dehydration, any electrolyte imbalance because of diarrhea. Okay. Any infections are there, you have to correct the infections. After the child is discharged from ICU, now the child is into regular ward, micronutrient deficiencies can be corrected. Okay. Here you can notice when the child is undergoing treatment in the ICU, you are not focused more on iron. Okay, because in the ICU, if the child's iron rate is severely low, if the child is severely anemic, we have the option of blood transfusion. Okay, so in the initial treatment of that 1 week, we don't focus on iron, but once the child is into the ward for nutritional treatment, your focus will be on iron along with other micronutrient deficiencies and macros. In the ICU, you will not dump the child with high calorie food. Do not do that because the child will be on IV fluids. Child is getting a lot of nutrients from the IV fluids. So do not dump the child with a lot of high calorie food when the child is in ICU because the stomach has to recover from malnutrition. It takes time. Okay. In rehabilitation, feeding will continue. You will increase the feeding in rehabilitation. In ICU, you will not increase the feeding. Okay, only to catch up with the growth, to gain weight, feeding will be increased only in rehabilitation phase, that is in wards, not in the ICU. Okay, you are not focused on the child's weight gain in ICU. Is the treatment strategy clear to all? Even in hospital, it is the pediatricians who will decide how much feed, how much ml of feed has to be given. It is the pediatricians who decide. Okay, nutritionists just have to give advice to the nurses. Okay, in ICU, nutritionists will not have major part. Doctors and nurses will take care of the nutritional part. But once they are in the ward, to catch up with the growth, to counsel the parents, okay, to help the child to be counseled, there is where nutritionists and dietitians will have their major role. Okay, in ICU, the feed quantity, what type of feed, what type of intravenous solution, everything is decided by the consultant pediatrician. So principles of management, correct the dehydration. Here ORS solution is used. IV fluids, the child will be put on IV fluids. So ORS along with IV fluids, ORS more in ward rehabilitation, IV fluids in ICU rehabilitation will take care of the dehydration. So dehydration first has to be maintained, otherwise you may lose the child. Then infections. For antibiotics, there has to be a bacterial infections. Do not prescribe antibiotics for viral infections. Okay, only when there is a requirement of antibiotics, only then prescribe it. whoever is the doctors here or pediatricians here, follow antibiogram, okay, to prescribe the antibiotics. Do not abuse antibiotics. You do not have to put the child into a multi-drug resistant condition. Then hypoglycemia, again with DNS, dextrose normal saline, dextrose solution. Okay, the hypoglycemia will be treated. Hypothermia, temperature of the child has to improve. It has to increase. Usually, hypothermia happens in cases of hypoxia. What is hypoxia? Body parts, usually the feet, legs, hands, palms, fingers, okay? These body parts of the child will not get sufficient oxygen. It becomes very cold. And slowly this coldness will spread through the body. Okay, it can shut down the heart as well. Okay, after a certain point. So to prevent this hypothermia because of hypoxia, child may be put on oxygen. Okay, oxygen supply, oxygen mask will be put on, the oxygen supply will be started for the child. So hypoxia will be corrected. And once the hypoxia is corrected, slowly hypothermia will also improve. Okay. In case of congestive heart failure, as I mentioned earlier, malnourished children, their heart size decreases. Heart size will actually decrease. The heart will undergo atrophy. Okay. So it's a small heart, big body. Heart has to pump a lot of blood, but heart does not have enough energy. Okay. Heart's muscles also require energy. Since the child is undergoing macronutrient deficiencies, heart does not have enough energy to pump blood. It goes into a congestive heart failure situation. So in that case, code blue will be announced. Okay, in ICU or in wards, code blue will be announced. Pediatricians will come. They will do the CPR. Okay, cardiopulmonary resuscitation CPR will be done to resuscitate the child. Okay, or other heartbeat starting medications will be given, like morphine and all. Okay, adrenaline, morphine, these medications will be given if the child goes into a state of heart failure. So these parts will be taken care of in ICU. Next is diet part, formula diets. Okay, formula diet is the basis of your rehabilitation phase in wards. Once the child is in ward, or even in the second to third day of ICU, F75 can be started. Okay, so what is this F75 and F100? F75, a packet of F75 will give you 75 kilocalories. Okay, F100 will give you 100 kilocalories. Okay, so always you have to start with 75. You have to start with less calories. Then slowly you will increase it to F100. Okay. So here in this table, you can see what all are the contents of F75 and F100. The only difference here is F75 has cereal flour, that is either rice or wheat, maize, ragi, or any cereal flour will be there. In F100, there is no cereal flour. Okay. F100, since it has high calories, basic contents will also be higher in quantity. Okay. So it is made with skimmed milk, milk powder, sugar, cereal flour, vegetable oil, mineral mix, vitamin mix, and water to make it. Okay. So 1 liter of F75, if in 1 liter of water, you mix this powder, you will get 75 kilocalories. Okay. And this 1 liter of water, can you give it to the child in one go? 1 liter of this feed, F75 feed, can you give it to the child in just one go? You cannot. Okay. So here, when the child is put on this F75 and F100, every 2 hours, the mothers have to feed the child. Okay. Maybe 200 ml, it can start with 100 ml. Initially, the child is only having 100 ml. Then after 2 hours, try to push 150 ml. Then after 2 hours, try to give 200 ml, like that. Okay. Every 2 hours, every 3 hours, as per the pediatrician's recommendation. Okay. In textbook, they have given a specific time intervention, but when it comes to practice, it changes slightly. Okay. So every 2 hours is the general rate what we follow, 2 to 3 hours. Okay. So in every 2 to 3 hours, the mothers have to give, make sure the F75 feed is completed by the child. Okay. Again, they have to make the 75. In one day, the child may have 2 to 3 liters of the F75 feed. Okay, it can go like that also. But the main thing is you have to make sure to every 2 to 3 hours, the child is consuming the F75 feed, which has been made ready. Okay, and even if the child is sleeping at night, the child has to be woken up. Okay, and the mother has to, it's the mother's responsibility to complete the feed. Okay, and slowly, when you see the child's appetite is improving, the child is completing the F75 feed on time. Now you will understand, okay, you can increase the dosage. Now you will shift to F100. F100 also in the same way, every 2-3 hours, few mls you will give to the child, 100 ml, 200 ml, finish the feed within 24 hours. So based on this, when you use these two feeds, you will start seeing the changes in the child's weight. Okay, it's usually given to correct micronutrient deficiencies and macronutrient deficiencies as well, and also to put on weight for the child. Okay, so this is the formula diet, F75 and F100. Is it clear to all? So feeding on admission, be very careful for the nurses here. Do not dump a lot of high calorie food to the child the day when you get a malnourishment case. On day one, don't do this mistake. Okay. Feed the child only what the pediatrician has recommended. Don't overdo it. Otherwise, the child will go into a stage of shock. Feeding after improved appetite, slowly, in a very controlled pace, the quantity of the feed will be increased. Okay. In the textbook, when you read, you will get that. It is usually for the practitioners. Okay. But for all the other students, just know the day when the child is getting admitted, okay, you have to focus on correcting the child's life-threatening conditions, not to feed the child a stomach full of food, because otherwise the child will go into a state of shock. So feeding on admission, that is a thing you have to keep in mind. Okay, just follow the pediatrician's recommendation. After doing the initial examination, clinical examination, medical examination, the pediatrician will know how to correct the feed for the first few days in ICU. The next day is feeding after the appetite has improved. Once the child has started eating, enjoying and eating F75, you will shift to F100. Once F100 is also been successfully done by the child, then slowly you will introduce home cooked meal or regular meal for the child. Okay, so that is how you slowly add new varieties into the child's food. Whatever deficiencies are there, weekly once take the blood sample and check the micronutrient levels, macro levels, and if there are any deficiencies, accordingly multivitamins will be put into either into the feed or multivitamins will be put into the IV fluid to correct the deficiencies. Major deficiencies you have to be worried about should be vitamin A deficiency. For vitamin A, prophylaxis will begin, okay, the first 2 days, and few weeks after that, prophylaxis will continue. The nutritional rehabilitation encourage the parents to use more ghee in the diet, okay, guide them through the ration facilities, okay, certain rough diet and all, we will see rough diet soon, which is given free of cost in Anganwadis, okay, certain ready-made pre-mixed formulas are distributed from Anganwadis, from PHCs for children under the age of 5, even for breastfeeding and lactating mothers. Sattu Mavu, these mixes are available, okay, free of cost from PHCs and Anganwadis. So adding these things into the diet will not only improve the mother's health, but also the children's health. Okay. If the family is under BPL category, they have specific ration supplies. Okay. A child, if there is a child who is under the age of 5, there are lots and lots of under 5 nutritional schemes. Okay, as a part of the ICDS program, Integrated Child Development Scheme program, there are a lot of mother and child health schemes. Okay, under 5 nutritional programs are there, which the way whose motto is to make sure good nutrition is accessible to and universal to all. Okay, it's not just that India has this much tons of food. Okay, it should be that even though India has so many tons of food, does everyone has an access to it? Okay, so accessibility is a major cause of a lot of malnutrition. There is enough for all, but a certain segment of the population does not have the accessibility to this nutrition. Okay, so that's why we see a lot of malnutrition. So nutritional rehabilitation, you have to counsel the parents, okay, to add more idlis in diet, to add more chapatis in diet. How many chapatis can be given to the child? And when you're giving chapatis, how much teaspoons of ghee can be used? Okay, how much sugar can be given to the children? How can you increase the nutrition density of a food? Okay, to add more millets in the child's diet. Okay, these kind of counseling has to be given to the parents. The counseling points, certain important counseling points are mentioned in your textbook. You can read that later. Under the age of 24 months, growth monitoring is recommended. It is important. Road to growth chart has to be maintained either by the parents, the clinicians, the pediatricians, or the Anganwadi workers. Or ASHA workers can also go to each and everyone's home and do the under 24 months monitoring. Okay, all the universal immunization schedule plan, it has to be given. All the immunization should be on time. It has to be given to the child. Follow-up is very important. In follow-up, the clinicians will be able to catch any deviations in the diet. Okay, the child who was discharged from the hospital was healthy, but in follow-up, if there are any setbacks, it can be corrected. So follow-ups are very important. And if the parents do not have enough money, it's usually seen that after discharge, the parents don't get the child back to the hospital because they are afraid of expenditure. Okay, so guide them through free healthcare services, or even if the follow-up has to be done, it can be done at sub-center or PHC levels. Okay, in sub-center or PHC level, follow-up can be done. So that the parent, for every follow-up, the parents don't have to rush to the cities, spend a lot of money. Okay. Diet during convalescence. There are certain points given in your textbook. Please read through that. That is the exact guidelines you have to give to your clients. Okay. Or any parents who are dealing with a malnourished child. The diet during what is convalescence? When the child is out of life-threatening conditions. Okay. The child has been discharged. Even though the child has been discharged, you can't say the child is completely healthy. The child is in the convalescence period in which the child is moving towards its optimal health. Okay, it is the movement towards the optimal health. Optimum health is a destination. The child has not reached the destination yet. It is on the way. That is convalescence. So you should not have any setbacks during this convalescence. Okay, the income of the family, social factors, okay, other environmental factors like infectious environment. These things should not affect the child if the child is on convalescence. The parents have to take additional precautions for that. Okay. This is the rough diet, or called as Malai mix. So it took almost 7 to 9 years for National Institute of Nutrition (NI) in India, in Hyderabad, to come up with this formulation. Okay. So what is the importance of this rough mix or Malai mix? Okay, it is made up of peanuts. Okay, peanuts are high calorie food. Okay, they are high in protein, in carbohydrate, in fat. Okay, why this was such a hit? Okay, why it solved a lot of nutritional problem? Because you don't have to store this in fridge. No need to refrigerate it. Okay, you don't require any other uh, products to make this malai mix. Okay, it is ready made. The parents, they just have to tear the packet and give it to the child. Okay, the child will eat it like a candy. Okay, like a five-star candy, the child will just eat it. Okay, so that is the ready to use therapeutic food. The full form of rough diet is ready to use therapeutic food. It is made up of peanut. So children who have peanut allergy, they cannot use it. Okay, but peanut allergy and all is not that common in India. It is more common in the urban cities or western population. They are more prone to peanut allergies, but in India it's not that common, peanut allergy. Okay, so here you can see one sachet of rough diet can give 500 kilocalories. Okay, and this is given only for children who are above 6 months of age and who have been diagnosed with severe acute malnutrition. For them, the rough diet is given. Okay, and the ingredients used in rough diet is given here: roasted peanuts, sugar, milk powder, okay, vegetable oil, vitamins and minerals complex is given. Certain antioxidants are also available and some preservatives are there. Okay, so you don't have to. Once the rough diet has been begun for the child, do not stop breastfeeding. Okay, exclusive breastfeeding is recommended. You have to continue it up to 2 years of age for the children. Even if the child is taking this malai mix or any other mix, okay, breastfeeding should not be stopped. So you can see here how it is made in the sachet itself. The mother or the caretaker, they just have to knead the sachet a little bit just to break it down, easy, to make it easy for the child to chew. Okay, knead it a little bit, tear it open, and just give it to the child. The child will just squeeze and eat from it. Okay. So prevention of severe acute malnutrition, health promotion. Um, Women who are planning to be pregnant women, and lactating mothers. These are the target group in which, on which health promotion talks, health education talks to prevent malnutrition in children can be given. Okay, you catch them early. The group of mothers of under 5 children, lactating mothers, pregnant women, and women who are planning to conceive. Okay, these are the target groups whom you have to catch uh, for who are in the family planning task as well. Even for them, health promotion guidelines should be given, because mother's health is also important. Okay, mother who is deficient, mother who is malnourished will give birth to malnourished children. Okay, so health promotion begins even before you get pregnant. Specific protection, that is, make sure women are encouraged to follow through the universal immunization schedule for themselves as well as for the children. Okay, so that will give them specific protection against specific infections that are very rampant in India. Okay, early diagnosis and treatment, teach women, young mothers and women, the importance of upper mid arm circumference. Okay, so that will allow the mothers to be vigilant on the health status of their child, nutritional status of their child, and if there is any deviation from a normal healthy uh, nutritional status or at early, even before it turns into kwashiorkor or marasmus, these situations can be caught. Then ICDS, that is Integrated Child Development Scheme. ICDS has a lot of nutritional and health promotional programs. It is funding a lot of nutritional and health promotional programs, especially for under 5 children, mothers of under 5 children, pregnant mothers, lactating mothers. Okay, they are all the target groups of ICDS schemes. Okay, even for school going children, Anganwadi kids, adolescent girls, ICDS has their own separate schemes to improve their health and nutrition. The nutritional education should be given in school. Okay, because a lot of teenage mothers do still exist in India. So nutritional education should be a part of school's curriculum. Okay, it should be a part of syllabus so that children will learn young, they will go home, they will teach their parents, and in such way, society itself will learn about the importance of certain food, how to promote health, how to prevent nutritional deficiencies.